waiting for a few more moments for Professor Stewart, who's just having a few technical issues with her Wi-Fi, so shouldn't be very much longer. Aha. Thank you, Ruth. We have just gone live, so you timed that absolutely perfectly. Well done. Welcome, everybody, to Setting the Rural Health Workforce Priorities 2021. RWAV would like to acknowledge the traditional owners of the lands on which we are broadcasting this event, and we pay our respects to their elders past, present and emerging, and we acknowledge the Aboriginal elders who may be listening tonight. Welcome everybody, and thank you for joining us for this special event. My name is Morton Rawlin, and I'm an RWAV board member and director, and I'm a GP. I have worked in the country, currently working in the city, but I am also the medical director of the Royal Flying Doctor Service here in Victoria. So I have a deep commitment to rural health. I thank you for joining us tonight. Tonight is the first of what we hope will be a series of panel discussions that offer our rural health community the opportunity to come together and discuss the priorities for rural health in 2021. Tonight we are honoured to be joined by the National Rural Health Commissioner, Adjunct Professor Ruth Stewart. We also have Sandy Chamberlin, CEO of the Great Ocean Road Health Service, and Harley Hayes, an occupational therapist from Bendigo and the recent winner of the 2020 Victorian Rural Health Award in the category of the Rising Star Award. So we have some great people. Just some housekeeping. Tonight's event is scheduled to conclude at 7, and we will strive to keep to that. Questions were submitted beforehand. Sandy and Harley will be asking the pre-submitted questions along with some of their own. For our audience members, you won't have to worry about your mic and camera tonight. So sit back and enjoy the discussions. But we do welcome audience comments into the panel on the right-hand side of your screen. Let's get started. To begin with, I'd like to invite Professor Ruth Stewart to say a few words. Ruth was appointed as the second National Rural Health Commissioner for Australia in July 2020. She has 30 years of experience as a rural generalist doctor with advanced skills as a GP obstetrician and 20 years of experience in rural medical education. For 22 years, Professor Stewart was a GP in private practice in Camperdown, so knows Victoria very well. And she was a visiting medical officer at the local public hospital there. Professor Stewart, welcome. I invite you to say a few words.
Thank you, Morton. First of all, apologies. I've had one of those days where the travel just doesn't work, and so instead of sitting in the quiet of my own home or even my office, I'm in luckily I have a meeting room in the Townsville Qantas Club, but you'll keep hearing, I can't ask them to be quiet, that would not be polite. So sorry. And look, I'd like to begin by acknowledging the traditional custodians of the land on which I sit. I'm seated on Thalgari Wajah land and Garamulbara land. It's called Townsville these days, usually. This land was traditionally cared for by the peoples of the Bindal and Walgurta Kaba nations. So I pay my respects also to the elders of these nations, past, present and emerging, and to any Aboriginal and or Torres Strait Islanders who are with us today. So, look, I'm happy just to answer questions. Then I'll know what things you want me to talk about, really. So,
thank you, Professor Stewart. I will now hand over to Harley to tell us a little bit about himself and his work. Harley.
Thanks, Morton. Hi, everyone. It's so exciting to be here tonight, having a chat with Professor Stewart and Sandy. Thanks, everyone, for coming along. So I'm an occupational therapist and a behaviour support practitioner with Everyday Independence. The company I work for, Everyday Independence, is an organisation committed to supporting people with a disability to reach their potential and to support people across the country. So I currently practice in Bendigo and the surrounding areas. One of my favourite parts of my job is, well, probably a bit more prior to COVID, was the travelling and getting out of the office. I'm definitely fortunate in a role where I support people in their natural environments, in their home, workplace, in the community setting. And I think it's such a fortunate profession because there's not many jobs or we actually get to go into people's homes in their natural environments and support making a difference and living their best life. I'm currently in an organisational role with Everyday Independence where I'm working with quite an innovative team who are looking at developing new strategies and expanding workforce and creating equal access across several regions and areas. My passion area is working in disability, supporting people with a disability to reach their potential and live their best life. And my current specific area of interest is supporting people and improving quality of life for people who demonstrate behaviours of concern. So thanks for that, Morton.
Thanks very much, Harley. And, it's wonderful to see a young occupational therapist working in the bush. It's a great skill to have. So now I'd like to hand over to Sandy just to tell us a little bit about her and what she does. Thanks, Sandy.
Thanks, Morton. And I too am delighted to be here. I'm currently the Chief Executive Officer of Great Ocean Road Health, which is arguably the most beautiful health service in the most beautiful part of Victoria. Great Ocean Road Health, I see people nodding, so they agree. Great Ocean Road Health is a newly amalgamated health service, so we combined two long-standing health services in the communities of Lorne and Apollo Bay, Lorne Community Hospital and Otway Health, to form Great Ocean Road Health. Both health services provide all care to the community, from community care, GP care, urgent care, inpatient care, both acute and respite care, and aged care. So basically a one-stop shop for health in our communities. We're unique in that because of where we live, we don't have a winter bed plan or a winter increase in activity, though this year has been a little bit different. We are unique in that we have a 30 times increase of population in summer. So our workforce, our summer preparedness is a huge part of our life. A little bit about me. I've worked in health all my life, originally in medical imaging and then in health management, and now as a CEO in a public health service. I've worked in public, private and not-for-profit health in Australia and overseas, but the last 26 years I've been in Victoria, and 23 of those have been in rural and regional health. I have a passion for public health and providing health care to those who need it the most. And we have a catchphrase at Great Ocean Road Health that we provide great care to our community. And I'm delighted to listen to what Ruth's got to say tonight and hopefully ask some challenging questions on behalf of you and me.
Thank you, Sandy. it's great to have you on board, and I'm sure that this is going to be a really interesting discussion. So let's get it all started. Some question time. Harley, I might throw to you to start with the first question. Thank you.
Perfect. So, Ruth, COVID-19 has presented many challenges over the last year, and in many rural communities, further limiting access to services. However, do you think that there have been any key learnings that will actually increase accessibility to services in the future?
Look, I think the shorter supply chains that have occurred during the COVID-19 has been a big learning for both rural communities and the cities. So we know, we know that those communities that were self-sufficient were safer, and those communities that relied on locums had quite a bit of difficulty, obtaining staff and providing service because they didn't have the staff. I think the other thing we learned was that when there's an emergency, the Commonwealth can actually respond very quickly. I think it's an amazing thing that the GP respiratory clinics were set up around Australia in 1 week. That's phenomenal. And it's not just that they were set up next to the Department of Health in the city. There were GP respiratory clinics in some of the most remote communities in Australia. They rolled them out. They, fixed problems as they came up. So that was really exciting to see that. And I think also the point of care, rapid rollout of point of care testing to rural and remote services. There were 86 Tango test, treat and go programs rolled out. I know that Torres and Cape Hospital and Health Service, where I'm based, so that's the Cape York Peninsula and the Torres Strait, benefit from, I think, 4 of those units, so that instead of the 3-day turnaround for test results, we could give patients a 40-minute turnaround. For example, I had a bit of a tickly throat one day when I was about to head down to meet Greg Hunt, and I was able to get that test done rapidly. I was very grateful for that. Yeah.
Thanks, Ruth. I do think it really does highlight a couple of the challenges we experienced, especially in the locum workforce, but also how fast we could adapt when we needed to. So thank you for that.
Yeah.
Okay, over to me. Hi, Ruth. This is actually my question. One of the biggest challenges we have in our tourist community is providing accommodation for those we recruit, both our skilled workforce, our GPs and our skilled nursing and other clinician workforce, but also our non-skilled workforce. We find it really difficult in a tourist area to assist in any sort of rental or permanent accommodation for our staff, which really limits us to provide a service at times. We've gone through various grant applications and infrastructure applications for funding, but no one seems to want to fund accommodation or staff accommodation. Is this something that you've considered or could be considered in the future?
Look, to be honest, the usual solutions that are found around Australia are cooperative ventures with local government authorities. New South Wales back in the 1990s did quite a bit of work in setting up they call them, hang on, goodness me, I think I just heard my flight being called. I'm just sorry about this. I'm just going to have to check.
Trouble of airports and travel, isn't it?
It is. Yeah, it's
Yes.
an interesting solution. And we have had discussions with the council all the way along the Great Ocean Road. That has been a real difficulty. But I understand there'll be solutions that would have been considered in other parts of Australia. So
Yes.
interesting to hear your point of view, Ruth.
Yeah. Oh, look, I'm sorry about that. This is a little Qantas-link flight between Townsville and Cairns that I'm trying to take, and sometimes if the plane arrives early, they run it early, and I heard them say Cairns, but they were saying it's going to be late, so it shouldn't be. And the lovely lady at the desk is going to come in and drag me out when I need to go.
That's good.
Being a platinum frequent flyer. Now. Yes, so I was talking about the New South Wales models where, it was they tended to describe it as walk-in, walk-out, so that to remove some of the barriers for doctors. It was particularly aimed at doctors, and it was established by RDN New South Wales. They sort of set up, the process, but it's the local governments that provide the housing. So, but I know from my time in Victoria that Victorian local governments have quite a different attitude. I still remember when we sent a letter to the Corangamite Shire Council, who are, Camperdown, where Camperdown is placed, asking if they would consider such a model. And we got a letter back saying, we don't support the local shoe shop owner. Why would we support your small business? Which we found interesting. Yeah. Shoes are. I know shoes are important. Yeah. Anyway, but the challenge though is that New South Wales is now, even in those towns that have the walk-in, walk-out models, they're having trouble finding doctors. So I'm sorry, Sandy, I don't have I certainly don't have any knowledge of any. There's certainly I am not aware of any government programs at all to provide housing for health staff. And in Queensland, actually, the hospital and health services do provide housing for employees. So, I'm lucky enough to be living in a lovely unit overlooking Thursday Island Hospital at present. Great view. But, that's Queensland.
I think I'm just going to have to continue to advocate and with the local government and state government and find solutions.
Yeah.
Thanks.
And look, I think the way to structure your argument is to point out that in a community that has a stable health service and public transport, the community will grow. People will leave a community when there isn't a stable health service, and if surely it's in the interests of the local government agency to actually support the health service. And this is, they've got land and they have access to pretty good loans as well. Yeah.
Thanks. Yep. Thanks for that.
If you are lucky enough to have a university rural unit in the town where you are, sometimes that is worth also approaching because they do sometimes have accommodation when they don't have students, or they may have some excess. Doesn't always happen, but you can always, use your networks.
Yeah, as I understand. So Deakin Medical School is your local one, and certainly I established the rural program for Deakin Medical School, and there wasn't any rural clinical school infrastructure built along the coast there, mainly because of the difficulty that you have with a supply of medical staff. So, and there hasn't, and since I left, there hasn't been any further infrastructure money coming into rural clinical school programs. So I'd be surprised if Deakin has anything on the coast there. Sorry.
It's worth a thought.
Thanks, Sandy. I think it raises one of the biggest challenges faced across a number of different rural and regional communities, and sounds like some of the time it's just a bit of a luck of the draw in terms of your local area or where you're based or the state you're in. So it's definitely a consistent challenge. So Ruth, it's an exciting time for rural health, as Australia is about to test new innovative models of primary care to address rural workforce shortages, such as 4T's experiment and the Murrumbidgee model in New South Wales. What outcomes do you hope to see which will indicate these models have been successful?
The outcomes would be increased numbers of, so for the Murrumbidgee model, increased numbers of rural generalist registrars enrolling in the program in the Murrumbidgee area, because they are particularly challenged there. For the 4Ts, let's see if I can remember the names of each of the towns: Tullamore, Trangie, Tottenham, and Tullamore. Did I say? No, I started anyway. 4T said four towns starting with T. I'd never get them all. 4T towns starting with T that sort of surround Dubbo to the north and west, and they are all even what I would call small towns, smaller than they're more the size of say Terang or Rushworth, thinking. So they're small towns, and they have only ever had solo practitioners. Now, the solo practitioners who have been there for many, many years are retiring or approaching retirement, and the local health service has networked them both through their medical records and is so the 4Ts model is that there will be 9 to 5 medical services Monday to Friday in each of the towns, and because of the networking, they will be able to provide after-hours care in a networked manner. So that by telehealth, unless you happen to be in the town, where your doctor is on call tonight. And I don't see that there's an issue with that. That's a kind of service that has been provided for the last 30 years in the Torres Straits, and you just need to know how to do it, and it works. But people don't like change. I think really it's a great model, and it's a great answer to that challenge of how to provide health services to a small community. So for Tottenham, for the 4Ts, a successful outcome will be having young doctors who are prepared to go and live there and work, and they're actually feeling pretty confident that is going to happen. The Wentworth model is really looking at a more this is one that I'm less familiar with so far. It's only just been announced. They're looking at a collaborative effort. So really all of them, for each of the innovative models of care, the goal is to have a health service that is functioning in the community, because, and it's been necessity that has driven the development of these innovative models of care, because the way healthcare has been delivered in these communities is not going to work into the future. So, they've had to change what they're doing. Yeah.
Thanks, Ruth. I think that it really does highlight the importance of being really innovative early and doing that workforce planning, and then setting it up so we have a model that promotes sustainability and longevity, so we're not continuously revisiting similar issues. It's really exciting. Thanks.
And can I just I'm going to mention here, 60 Minutes did a story on some really sad medical, misadventures really in Western New South Wales, and they've somehow linked the telehealth provision and they keep saying that doctors are being replaced by telehealth. So if anybody has an opportunity to say, actually, that's not the case, where telehealth is being implemented is where there aren't doctors. And yes, everybody agrees that telehealth is a wonderful tool to give people access to healthcare where they wouldn't otherwise have it, or perhaps to allow them to remain at home and access healthcare when otherwise they would be required to travel. And yes, so for those of you who are on this teleconference, it's helpful if you can have an opportunity to correct that misunderstanding.
Thanks, Ruth. It definitely presents us some risk when you have information like that being dispersed, because it does create increased accessibility to services. So thank you for that. Thanks, Sandy.
Yeah, there's nothing like a pandemic to increase the use of telehealth, which we've all wanted for years and years and years. The other side of telehealth is the patient experience. I've had multiple compliments regarding our uptake of telehealth. Satisfaction because they don't have to leave their home, their script gets delivered to the pharmacy, the ease of service. I think, putting the patient back in the centre of telehealth, it adds huge advantages when used in the right setting. I'm going to ask a question around maternity services. So in a recent interview on ABC, you said that governments have to stop closing maternity services in rural Australia. From our experiences in Victoria, there is a real recruitment and retention issue that in some areas we just can't get the workforce to staff these services, in particular GP obstetricians and GP anaesthetists. There is no additional financial incentive which covers the additional cost of medical indemnity insurance, and the low birth rates in the smaller centres mean that the specialists don't get enough practical experience. What are your thoughts around this going forward?
Okay, so look, I have had the privilege of working with a number of midwifery group practices over the years. By the time we left Camperdown, the service there had pretty much been transformed into a midwifery group practice, supported by the rural generalists. We moved to Mareeba. So when I'm saying we, that's my husband, Dr. Anthony Brown, and I are both GP obstetricians. So when we left Camperdown, we moved to Mareeba in North Queensland, where there was a midwifery group practice that had been working without any doctor support. So if there was intervention required, obstetric intervention, then women would have to be transferred in labour down the Coranda range. If any of you have ever driven up to Coranda from Cairns, you might understand that that isn't such a pleasant thought. And then we moved to Thursday Island and instituted a midwifery group practice there. There's strong evidence that continuity of care actually reduces the intervention. Women are much more likely to have a normal birth. There's some really interesting, sorry, I'm getting off on a rant there. Anyway, I think that midwifery group practice allows midwives to practice the way they were trained and gives them a much more satisfying role. Working as a rural generalist with a midwifery group practice, a rural generalist doctor with a midwifery group practice means that you're not getting up so often at night. What's wrong with it? It's great. I mean, I really do love a normal birth, but, there comes a time when when you're going to bed and you're thinking that, when's she going to have this baby? And you think, yeah, it must be about time to give up. But if you're working with a midwifery group practice, they don't ring you if it's a normal birth, if everything's going normally. And when you have a strong relationship and a strong team, you don't need to be worried about what those midwives are doing, because they are your respected colleagues and you are their respected colleague and you work well together. So I think that for the answer for rural maternity services is rural generalist services and working with midwifery group practice. And I think that the establishment of the rural generalist program in Victoria is, I'm looking forward to it really positively influencing the rural medical workforce for health, rural medical workforce. Yeah. Have I answered each part of your question?
Yeah, that's right. I guess having an integrated approach to maternity care and looking at different models. Yeah, thank you.
Yeah. So I'll actually add one more thing. Strangely, women aren't very often asked what they want from a maternity service. Doctors and even midwives are really good at designing services for women because we know best, okay? But when you do ask women what they want, they talk about care by a known carer and that is relationship-based, and having information to help them make the decisions. So note that having information to help them make the decisions. So they're not expecting other people to be making decisions for them. They want to be able to make decisions themselves. And they want a respectful relationship. And those are the things that are consistently talked about. Women see those things as more important than the safety, which they assume is there. They want to see the relationship. And I think we do our women and our babies a grave disservice by not respecting that and making our maternity services sausage machines. Thanks.
Thank you.
You're right.
Thanks, everyone. There's some really great questions that have come through. Ruth, are you seeking to focus on improving access to allied health as part of a new solution for the rural health workforce?
So one of the things that I've become much more aware of since I've become the Rural Health Commissioner is actually the dearth of allied health practitioners in rural communities. So not only is it that, we know that the trickle-down effect doesn't work for health workforce, making lots and lots of health professionals in the city and expecting, a rational proportion of those to go rurally doesn't work. I have the privilege of following in the footsteps of Paul Worley, who was the inaugural Rural Health Commissioner, and he produced an excellent report on improving access to for rural communities to allied health services. And we are beginning to look at how the recommendations made by Professor Worley can be implemented. So I suppose I've already talked about the team in maternity care. I think that the best healthcare is multidisciplinary team care. That I know as a general practitioner, I can only do good work when I am part of a multidisciplinary team. Back in the day, which was a long time ago, that I was a medical student, they used to just talk to us about the doctor leads the team. You know, that is so wrong. Actually, we are part of the team, and if you're good enough, you may be granted leadership, and that is a real privilege when that occurs. But if you're not part of the team, things start to go wrong. So we really must improve the allied health workforce in rural communities, and we know how this can be done. We know that if you enrol rural students in the courses, if you give them early and positive and well-supported clinical attachments in rural and remote communities, and if you give them a well-defined career pathway that has into jobs where there is good support and ongoing professional development, people will go. And we have to start structuring that. And this Commonwealth government understands that and is, beginning to think about how that can be done. And that's one of the large pieces of work that is expected from my office. And I'm looking forward to the appointment of the Deputy Commissioner who will be an allied health practitioner. So I'll have two Deputy Commissioners. One will have nursing expertise and one will have allied health expertise. And one of them will be an Aboriginal and or Torres Strait Islander person.
I think there'll be some exciting changes for yourself too, Ruth, in that space. So I think that's definitely from my experiences what I've seen as well, is that when you have a really great training program that's built into the rural and regional communities, then you set it up with some really great placements and experiences for the people in those programs. The percentage of people that stay in those communities is significantly higher than when we train people away from those communities and then with the idea that it'll trickle back down to those rural communities. It's not a model that's definitely standing up against the one of actually training the local and regional community.
I often say we've got some great universities in Australia that do a wonderful job of turning rural students into urban practitioners. Why? Really? Why? They should be held accountable. I am holding.
That's a great quote. I might have to use that.
Couldn't agree more.
Yeah, couldn't agree more. We have the same experiences. Yeah. You talked before about your excitement about the development of the National Rural Generalist Pathway. Like the pathway into general practice specialty is confusing at the moment. Do you have thoughts on key areas that you're to advocate to inform the development of the pathway?
Yeah, look, I think the National Rural Generalist pathway was coveted, to be honest. There are only a certain number of people working in the Department of Health, and they were working night and day to respond to COVID, and we didn't get much traction for a good 7 months, really, on advancing the National Rural Journalist Program pathway. So there are key things. One of them is to we have had each jurisdictional coordinating unit established, and I've been in contact with the one for Victoria, and they've got some really good things happening, and there are others all around Australia. So that's one of the things. So for each jurisdiction to look at how they can oversee and make a very clear pathway, make clear the pathway to rural journalist work. So the training, so that an intern who is working in a regional hospital can go, oh, I see what I need to do to become a doctor like that, doctor in Horsham or Orion, that'd be a nice thing. Yeah. So that's the coordinating units. We are underway with an application to the Australian Medical Council for recognition of rural journalism as a specialised field within the specialty of general practice. Now, that takes a lot of words to say. Why is that important? If we have recognition of a specialised field within general practice for rural journalism, then accreditation becomes very much easier, and deciding how to remunerate people for their advanced skills as a rural journalist. So when say for me as a GP obstetrician, it becomes very much easier to negotiate how I am paid when I use those obstetric skills. Or if I was a GP anaesthetist, when I'm gassing, that sort of thing. So sort of overlapping with that is the transition of training to the colleges for the Australian General Practice training. Yesterday was the first meeting of the beautifully named TICKLE-TAC, the Transition to College-led Training Advisory Committee. And TICKLE-TAC is going to be meeting weekly. That is a ferocious pace for the department to be moving at. Michael Kidd, Professor Michael Kidd, who's the Deputy Chief Medical Officer, and I co-chair that committee, and both of us want to see this happening. So that's the other major part of it, really. And so, yeah, those are the major bodies of work to implement the National Rural Health Commissioner. My reputation as the National Rural Health Commissioner will live or die on the implementation of that program. So
well, I wish you every success, because for us trying to recruit, train, describe pathways for people, and encourage GP training, rural GP training. GPs have been trained rurally to stay rurally. I wish you every success. Thank you.
Thank you. Look, it's a wonderful privilege for me to be in this role, because this is the stuff, I went into medicine to be a rural doctor. I didn't actually understand that that was a different thing to what Melbourne University in the 1970s wanted to train me to be, until I was there and going, this doesn't know, I don't want to be a doctor, and realising that they really had no vision at all of the scope of practice of rural doctors. Yeah. So I've been agitating about this forever. So it's my very great privilege and honour to be given the title of Rural Health Commissioner and asked to get on with it.
Sounds like you're going to be busy, Ruth.
Well, yeah, I am. Believe me.
Another question from someone, but how can we ensure Aboriginal and Torres Strait Islander people are receiving culturally safe care when they visit primary care services?
So it's up to each primary care service to address their cultural safety. And look, I think there are a couple of easy wins. I have been involved now in a number of organisations that have had a reconciliation plan, undergone that process, and that's been really useful to shine a light on the institutional racism that white people, dominant majorities enact, and because you don't if you're white, you don't necessarily see, even well-intentioned people can act really inappropriately. So a reconciliation plan is a good start, and there are really, really easy things like acknowledging, having a sign in your waiting room acknowledging country, having Aboriginal and or Torres Strait Islander artwork so that people see that their culture is honoured by the institution. And I'm not saying go and get something from the Central Desert. Find your local First Nations people and ask, and consult and ask them what artwork they would like to see in your facility, and co-design. So, don't just have the conversation about the artwork, have a conversation about what the First Nations people in your community want from the health service, and what are the issues for them, what are the problems, what are the enablers, what are the barriers, and get to work on that. And then another thing, I said easy things. Okay, that's the easy one. The difficult one is to employ more First Nations people. And I'm saying it's difficult because there's a very long lead time. You have to, as somebody who's worked on this for a while, you need to engage kids in primary school. Aboriginal and Torres Strait Islander kids don't see Aboriginal and Torres Strait Islander healthcare professionals very much, so that they don't necessarily think, I could be that person. So you need to engage with the kids at primary school, tell them that we need you. We need you to come and be and, work with us for your people. And then you need to intentionally make it obvious in your advertisements for staff that you are seeking cultural diversity in your staff, and that First Nations people are encouraged to apply for the job. And then once the people are employed, having had a reconciliation plan, you can make sure that it's a culturally safe place for them to work and that they will be respected. It
really highlights the importance of having a multi-pronged approach and involving people in lots of different steps along the way, even at primary school, and supporting them to develop a vision of what there is out there and what they can be. So
yeah. We ran what we call deadly health jobs on TI, which is we ran for the kids from the local school. On Thursday Island is 85% Aboriginal and Torres Strait Islander people. You might think I'm making a mistake by saying Aboriginal and Torres Strait Islander. No, it is both Aboriginal and Torres Strait Islander. And we invited the kids from years 6 and 7 to come in for a fun afternoon of activity, which we ran pretty much like an OSCE. and we had about 10 stations. Every single station was run by a Torres Strait Islander health practitioner of one sort or another, radiologists, doctors, nurses, Indigenous health workers, and we told the kids that, absolutely told them, we want you to start thinking about a career as a healthcare professional, but the purpose of the activities was to get them just thinking about it and engaging with the concept. And we ran it in the clinic because we wanted them to begin to see that as a place that was safe for them to be. That had a real impact on those kids and certainly the way they interacted with the healthcare centre, which was great. Sorry, yeah.
That was great, Ruth.
Thanks, Ruth. Would you like to comment about, it's still difficult to get GPs into rural areas, let alone some allied health professionals. Have you seen any innovative approaches since you've become Rural Health Commissioner that we could all learn from or look to put into practice?
Look, I think I'm going to start with an observation that predates my appointment as the National Rural Health Commissioner. I won't. I've said this before, so even if there are people who are from Queensland in the audience, you might not be surprised to hear me say this. There are some godforsaken towns in Western Queensland that are doctor magnets. Okay, they are, they're too far away from anywhere that an urban person would consider a reasonable place to live. The quality of the latte is appalling. It rains, once every couple of years, and the most common activity is pig hunting and roo shooting. Like this kind of place. Okay, but they're doctor magnet. And what is it? It's because they have strong medical leadership that has established a learning environment so that they have medical students, they have junior doctors doing the Ridgy-Tiff thing, so interns. They have registrars, and they provide regular structured educational activities for all learners, including the established fellows, and they work and they all learn together. Vertically integrated and regular structured learning opportunities. And it really makes a difference. So in Auntie and my personal experience, that's sort of when we brought in those changes to Camperdown, we suddenly started getting really high-quality registrars when we'd been struggling to get any registrars. And Camperdown became a very popular destination, and we got some junior doctors, young doctors, to commit to the town. We moved to Mareeba in North Queensland, and it had been an absolute basket case. They had been running the town that had a population of about 8,500 people in the town and serviced, a much wider, surrounding population. They'd been running the hospital with three medical staff, and they'd had to temporarily close the birthing service. That 250 babies a year are born in that community. They'd started to get some doctors, but it was still difficult everybody was very, very surprised when we decided that we would go to Mareeba, and she chose it because it's got a good strong community feel. And our deal was I was going up to work for James Cook Uni, and because he'd agreed to move up there, he got to choose the town that we lived in the James Cook University patch footprint, and he chose Mareeba. Anyway, so we introduced that same learning environment there. When I say we did, he pretty quickly became the hub director of medical services for Cairns hinterland, and he instituted 4 days a week. There were tutorials and educational events of one sort or another. He harangued me until I tripled the number of medical students that were coming to Mareeba from, oh goodness, we're nearly time's up, so we had 3 times the number of medical students and got some of them staying all year. We increased the number of, they got interns up, and suddenly Mareeba, having been the basket case, within 2 years, the 30% of the rural generalist trainees that I was interacting with as a director of rural generalist training with that program, part-time as well as the JCU job, 30% of them were saying, in answer to the question that we asked each of them, in 5 years' time, where would you like to see yourself working? 30% of them were saying, Mareeba. Okay. We moved up to Thursday Island, and when we arrived, there were 3 permanent staff, medical staff there. We implemented those same kind of changes, and for the first time in living memory, Thursday Island has all medical positions filled. Not only that, but the number of medical positions has been increased by 45%, and even those extra places are filled, and we are turning away job applicants, and there's a very high quality. So we've seen that. And I could talk to you about Cloncurry, about Longreach, but then you'd know what towns I'm talking about being godforsaken. And it's about the leadership and the education. Yeah.
Yeah. It is about that leadership, isn't it, Ruth? Yeah, very much so. Look, we're rapidly coming to the end of our time tonight. I'd like to pass it over to you, Ruth, just to make any final remarks that you'd like to before we end.
Okay, thanks. Look, thanks, Morton. Sometimes people have asked me, what would I like to have to see as I exit this role? I hope that when my term comes to an end, that people will be going to their local member of parliament, not saying, give us a new hospital. They'll be saying, you've got to get us one of those, a team of those rural generalists. We need a multidisciplinary primary care team in our town, because that's what's going to make the difference to our health. We've heard all about it. That's what I want to be happening. I want not just the health literacy of rural communities to improve, but people's understanding of what will give them good health care. And I suppose I'd also like to see a lot more birthing in our communities, because that's the safest way to birth.
Sure. Thanks, Ruth. Sandy, any comments from you?
Look, what Ruth said really resonated around providing those integrated models of care and using nurse practitioners, midwives, extended allied health practitioners, which is something that we've all embraced. I too don't want to lose the innovations and the steps forward that we've done during COVID in the provision of telehealth. So I hope we can continue to advocate down that.
Thanks, Sandy. Harley, would you like to make some comments?
Oh, I think I completely agree with what everyone said. I think there's been some challenges during COVID, but there's also been some really key learnings, and I think there'll be some really big advantages that come out in the future, and especially around being really self-sufficient, but also the promotion of technology and how we can best use that to not replace anything, but to build on what's currently working and support everyone in having access to best practice services.
Yeah. Thank you. And look, I totally agree as well. It is about an integrated team. It is about knowing what are the services that your local area needs and making those services communicate effectively so that you get the most out of them. And asking the community what they want. Because if you don't do it with your community, it's okay. So look, thank you everybody. We are at 7:00. I really do like to thank Professor Stewart for her time tonight. I hope you get on the plane okay. And thank you everybody. Good night.